came back right after that too. My association with this building, it goes way, way back. My mom was the person who was in charge of the city through various mayors. If anybody ever did any business with Mayor Gallo, Mayor Heitzman, Mayor Mancuso, Mayor Quick, Mayor Satile, probably dealt with my mother. So I spent a lot of time in this building before it was renovated, and then once in a while it was being renovated, and afterwards too. It's a perfect room to hold this forum in because it's a demonstration that we should never lose hope. This building sat vacant for many, many years, and a lot of people thought that it was going to just crumble into ruin. And look at it today; it's a magnificent structure, and it's provided a great forum for community meetings over many, many years now. And it's a great opportunity that we have today. What this forum is about, what I hope will happen today, is there's been a lot of talk, a lot of speculation. There has been, the latest thing now is blog entries and comments associated with newspaper articles about what may or may not happen with the Health Alliance of the Hudson Valley and the two hospitals in particular in Kingston, the Kingston Hospital and the Benedictine Hospital. I thought that it was important, and I asked the executive team and the board if they would submit themselves to questions directly from the public in a forum that would allow for a good exchange, fair and respectful exchange, and one that was very similar to the programs that we put on a couple of years ago before the Health Alliance was actually formed. Those of you who, and I see some of you who did attend those meetings, you might know that we held 5 meetings all over Ulster County to discuss the future of the hospitals. At that time, we knew that the hospitals were facing critical times ahead. There was also something out there called the Berger Commission, and the Berger Commission was making decisions all over the state to close hospitals and nursing homes, and our community said, we have a better idea, let us do it ourselves, and that's exactly what the forums helped accomplish. We came up with a plan, we meaning people like you in this room, the people on this dais today, people who registered their views in other ways, and ultimately the community offered a plan to the Berger Commission, which the Berger Commission accepted. And then when it was accepted, we were chosen to be the model of how a community can be proactive in the process of consolidating healthcare in the 21st century. We received very significant amounts of grants from the state. Those grants, I believe, were put to very good use in helping forge what was necessary to bring about the consolidation. You'll hear more of that if a question is asked, and if it's not, then I'll be happy to ask the question myself. I think it's important that you know how your tax dollars were spent over the past several years. We've seen some remarkable changes in healthcare too, remarkable both in a good way and a bad way. People, believe it or not, are healthier than ever before. And that means they don't go to the hospital as much as they used to. And when they're sick, they get treated in an office instead of in a hospital. And when they do go into a hospital, they leave pretty quickly. That's a change in the way healthcare is provided to our communities. And it was a change that has been accelerating rapidly over the past several years. And perhaps it's a change that's partially responsible for the circumstance we find ourselves in today, where our plan, this community's plan, was to go ahead with 2 quasi-independent campuses for hospitals and continue to provide a full range of health services in the community, but to do so in a way that was coordinated between the entities so that they could take advantage of the economies of scale and a number of other efficiencies that would have been available. What happened just a few months ago was there was an announcement basically by the hospital that there has to be some consideration of significant structural changes to the institution. That's okay. You know, that it really is okay. Healthcare is dynamic. Providing it should be something that we always look at ways to do it better, to do it more efficiently, to make people healthier, to make it less expensive for both health insurers and government payers, and also for individual private patients. So that's where we're at today. I kind of stole a little bit of what I think Dave Lundquist's speech was ask is that based upon the number of questioners or speakers that we have, you'll have to leave it to me to decide how much time you actually get for your question, and panelists, how much time you get for your answers. What we want to make sure happens is that everybody who came here tonight with a question has a chance to ask it. You may not be fully satisfied with the answer. I'm going to ask you to limit the follow-ups. There's a logistical issue about how you have to ask questions that will make it a little more difficult for me to enforce that, but I'm going to count on your good graces to make sure it happens. What I'm hoping is that at the end of the night, because of the range of questioners, the range of speakers, we have a much better idea of what's going forward, and that these folks sitting on the panel have a much better idea of what's on your mind and where you think we can go in the future. I will urge you also to look forward, not to look back. We can look back all we want, and we can blame, we can see who's responsible, we can see what's going on, or we can work together to make sure that we provide the best health care for this community. And we do that by offering our constructive suggestions, in some cases constructive criticisms, in every case making sure that there's as much transparency as possible. And with that, I will just start by introducing, not necessarily in the order of the sitting, but we'll start with Cynthia Lowe, who is the chairperson of the Health Alliance Board of Directors. Cynthia's, how long have you been chair?
I'm in my second year.
You're in your second year. Also, we have Dave Lundquist, who is the president and CEO of Health Alliance. We have Kevin Ryan, the vice chair of Health Alliance, and president and CEO of the Valley Group, and I believe Kevin, a former member of the Benedictine Board. And then, I don't know who this guy is on the end. We didn't ask him to come here tonight. He just showed up on his, no, I'm kidding. This is my starting in kindergarten classmate, Mark Zasevsky, Dr. Mark Zasevsky, who has many, many titles. He's, of course, any of you who have ever had anything to do with the Family Practice Institute know that Mark is a critical part of the Family Practice Institute, a well-respected physician in our community, and also a healthcare consumer in our community. He's the program director of the Mid-Hudson Family Practice Residency Program. He's also the vice president of the Joint Medical Staff of the Health Alliance of the Hudson Valley. Mark is a graduate of Colgate. He attended the Stony Brook School of Medicine, and those of you who know what ESPN3 is will know that Stony Brook just came back from the College World Series last week, a very important event. University of Wisconsin St. Mary's Hospital Family Medical Residency, and believe it or not, as youthful as he looks, Mark has been practicing medicine for 23 years. We're old, Mark. With that, I don't know if I'm going to ask each of the panelists to make an opening statement, but I would like to start with Dave to give us a little synopsis about how we got to where we are here today.
Sure. Thank you, Kevin. We've had, since the announcement, we've had many, many meetings to provide as much information as possible to be sure that since what we're talking about here is not just a hospital issue, it is a community issue. It's been very important for us to be as open as we possibly can, and that's been an approach that we have tried to do from the beginning. In many of the meetings that we've had with employees, with community groups, with our physicians and others, let me start and just kick off the discussion with the one that has been asked the most, the question that probably, hopefully, will generate many questions from you, and that is, what happened? Much was done to celebrate, as Kevin mentioned, the alliance coming together and what it was able to achieve. What has happened since that occurred over 3.5 years ago? And I'll attempt to just, as briefly as possible, hit the high points, and then we can open it up. But the Health Alliance was formed, it became active in March of '09. It was formed after 2 years of some very intensive planning by many, many community members. Primarily, many other things, but primarily 5 issues, pieces of the platform. One was to preserve and enhance the health care for this community going into the future for generations to come. Secondly, one of the components was to keep both hospitals open, to respect their individual missions because of the history of over 100 years each. Preserve jobs was another leg of this platform. Reduce beds. The Berger Commission was charged with reducing beds in the state. There was, at Benedictine, 222 beds. Kingston had 160 for a total of 382 beds. Under the Berger Commission recommendation, that was reduced to 300. So 82 beds, licensed beds, were removed. It was split 150 beds to each of the two hospitals. The fifth component was to preserve reproductive services for the community. And that was the basis for Foxhall Ambulatory Surgery Center that was constructed and is immediately adjacent to the Kingston Hospital. Those were the 5 primary reasons of the platform. The first year of the Alliance, we were very successful in hitting on all buttons. We pulled over $14 million of operating efficiencies and generated just under a $5 million operating gain. We were able then to provide raises to employees for the first time in 3 years. We have since provided 2 other raises for employees as part of that commitment. But since then, there have been changes, much to what Kevin talked about. The economic collapse of late '08, we didn't feel it until late '09. Unemployment, which translated into high deductibles and high copays. The end result of that is that individuals were not electing to receive care. We saw a volume decline. We've seen changes in reimbursement over the last 3 years, much propelled by the health reform movement, much needed, but still an effect that did result in some decreases in reimbursement for services provided. We also saw payer incentives to take procedures out of what had historically been in the hospital only, now into doctors' offices and to other facilities, such as ambulatory surgery centers and others, imaging centers, other services of that nature, again, taking services out of the hospital. And we've also, as a part of the health reform movement, there are very stringent requirements for heavy investment in technology, specifically to establish and be a part of the electronic health record to the tune of several $1 million. This will improve access to for all of us into health care, but it's a very expensive technology, and if we do not have this in place, there are very significant penalties in reimbursement for not doing it. So we have invested accordingly. So the cumulative effect of all of these changes has disrupted the original model that was successful under the industry environment at that time. So we're left with a choice. We must make the necessary changes to ensure that we evolve with the changes, keep it dynamic, and continue to move forward. I don't know, there's much more information, but in lieu of being sure that we allow time for questions and listening, I hope that may help for you to understand some of what we've experienced over the last 3 years that have changed the environment that requires us to continue to look for ways to adjust to the changing environment.
Okay, Dave, thank you very much. I want to follow it up with a second question to you. You've kind of given us a summary of how we got to where we are, understanding that the healthcare environment has changed, reimbursement has changed, both at the public and private level. Practice of the habits of people seeking health care have changed dramatically. Your competition has changed very significantly, and you've mentioned several other factors. An announcement was made, I think, by you a few months ago that there was a possibility that one of the 2 Kingston campuses would have to close. That was
obviously, this is not an easy process, and we're in the midst now of a very intense planning process in which we're evaluating all options. It is clear that we currently now have 300 beds operating at about 70% occupancy with the changes in healthcare. That is not a sustainable financial model. So we must look at ways to reduce our excess operating capacity. And in doing that, that's where we are at this point in determining how we do that, what are the factors that are critical to those decisions. And I can tell you that as we look at evolving into, and if you think about it, 2 fully operating facilities with only 70% occupancy spreads us too thin. We're not able to reinvest the dollars into services that we know need to be provided going forward. So it is critical that we look at ways to become more efficient, streamline our operations, reduce our excess overhead and carrying costs so that we can then focus all of our funding, all of our services on what is needed for the community going forward. That requires us to become a bit smaller. Our commitment is to come out of this better and stronger, a bit smaller. But the planning process we're in currently is evaluating all of the options. And in effect, we have 2. We have the Kingston Hospital and we have the Benedictine Hospital. Each of these options have pros and cons. And that is the part that we must be extremely careful to be sure that we weigh all possibilities so that the right decision can be made, not just a decision.
So if I understand what you're saying, you're suggesting that, well, you're not suggesting, you're outright stating that there has to be significant structural changes to the way healthcare is delivered in this community.
Yes.
And a likelihood is that a single campus model is one of the things that you are considering. Are there other options that you're considering besides a single campus model?
For our primary services as a hospital, we feel that the efficiencies gained by that are significant enough that that is our primary focus. And then, obviously, a sidebar to that is there are ongoing discussions as well to look at alternate uses for the other facility as we go through this.
Healthcare uses?
Very possibly.
I want to throw a third question out there. This would go to Cynthia and Kevin, with your experience as board members, and turning back the clock to before the Health Alliance agreement was entered into, when there was a Kingston Hospital and a Benedictine Hospital, and then the last several years happened. What is your estimation of what would have happened if the alliance was not entered into? Either one of you want to address it or both, that'd be great. Where would we be today without that?
Well, I think we pretty much know where we'd be today. The Burger Commission...
Louder?
I'm sorry. When Kingston and Benedictine started talking about some form of an alliance, that was just around the time the Burger Commission was being formed, and our conversation started prior to any directions from the Burger Commission, although we did know that there was a movement to reduce the number of beds, particularly in the city of Kingston. And if you will remember, and we all need to review our history sometimes, the Burger Commission told us here in this community that we would reduce the number of beds and we would provide a full array of reproductive services. And if we didn't figure out a way to do it as a community, then they would make the decision for us. And based upon those 2 parameters, it was the assumption of both the Benedictine board at the time and the Kingston board at the time that that meant that Benedictine would be closed. We as a community felt that that would be disruptive and a very big problem for everyone in this community if we could not find a solution. And so we attempted what we felt and what the state felt was a very creative solution, which was to build Foxhall, provide reproductive services in a standalone facility, and allow 2 hospitals with 2 separate missions to continue. And we had a viable business plan that, as Dave just pointed out, worked for a period of time. But I think we all know that we are in an environment where many business plans in the last few years have failed for a variety of reasons. We've had very difficult economy. Obviously, the issues and changes in healthcare have all contributed to that. So I think we know where we would have been had we not come together as an alliance. But I do think that we learned a lot through the alliance. We came together as a group of individuals to create Health Alliance. We rarely talked about Benedictine or Kingston as entities, but as part of a larger alliance delivering health care. And I think the last 3 years have allowed us to move forward in a way that will allow us to create one campus which will deliver exceptional health care to this community. And I believe that all of us involved in Health Alliance, and it's certainly the responsibility of the board to make sure that this is true, we are providing health care to a community that we care about and in which we live. Many of us hope to die in this community. And as a result, we are very concerned about the health care today, but the health care tomorrow. And we are trying our best to figure out how to deliver the most health care and the best health care that this community can afford to pay for. And unfortunately, money does come into it, and we have to figure out how to make the best health care economically viable in this community.
Kevin, you want to-
I would just reiterate that we would have had one hospital, clearly. I mean, that's the short answer. And I think Cynthia provided a lot of background information and history, but clearly we would have had one campus, one hospital, and I certainly wasn't in favor of that. I don't know if anybody was at that time. So it's brought us to where we are today, which ironically it looks like we may end up with one campus. But I think in that process, we've grown very close. What were 2 distinct institutions with their own separate identities, I think we've grown very close and act as one. My sense on the Health Alliance board is that we're thinking of community first. And we certainly, our long-term plan is to maintain a high quality of health care right here in our own community. I was born here, and as Kevin said, other than my years of schooling, came back here after college and plan to hopefully retire here. So Kingston has a very close spot to virtually all the board members. So we're as concerned, and I'm very interested to hear what you folks have to say tonight.
We will get to that in just a couple of minutes. We're pretty close to what I perceive the schedule would be, maybe a couple of minutes behind, but we're doing okay. I do have a quick question for Dr. Chesesky, Mark, about the state of healthcare, Mark, and the changes that you've seen over your several years of being a practicing physician, and whether the most recent changes that we've seen have been coming more fast, more furiously, and how they've been impacting your professional responsibilities.
Most of my practice in family medicine is outpatient. I train physicians, and we have to care for our patients in the inpatient setting. So what's pertinent, I think, tonight especially, is what's the nature of practice at or in or with a hospital in a community setting. When I trained, everybody who had their gallbladder out was in the hospital for 5 days. Most of you who are over 50 remember those days. You couldn't get home in less, and if you had a single complication, you were in for a week or 10 days. When somebody had their appendix out, you were in for 2 days or 3 days. When somebody had their tonsils out, they were in the hospital for 3 days. If you had asthma, once you came in, you weren't getting out for 5 or 6 days. It took that long to get better. Now, with improved antibiotics, improved treatments, improved therapies, infusions at home care nursing being able to deliver this, doctors' offices being able to deliver these therapies, appendectomies, cholecystectomies being done through with a laparoscope and a 1-inch incision. People go home the same day or the next day. Asthma is almost never admitted to a hospital anymore. When we do, it's complicated with pneumonia or chronic bronchitis. These changes have led to many fewer hospital days. And the day that somebody comes into the hospital, we start thinking about sending them home. They may not go home the next day, but we're planning for when they're going to be discharged because the insurers are asking that question from the get-go. Within the last 6 months, we've been instructed by the state and by the payers that they will no longer accept the standard of care that we admit a patient to the hospital with chest pain. We now are expected, insofar as possible, to admit them for what's called a 23-hour hold admission if they have chest pain, because so many chest pains prove to be benign, non-cardiac, but we cannot tell that for the first 10, 12, 24 hours. And if they're admitted to the hospital at a hospital rate, the insurance company feels like they're overpaying. So now they've created a new rate put out by Medicare and adapted by other insurers that pays a 23-hour rate that is substantially less than their hospitalization rate, with the expectation that we get them out in less than 23 hours and 59 minutes. If we can't, if it turns out that they have a heart attack, we can convert them to a full-day hospital stay, and they can maybe be there for 2 or 3 days, unlike my father, who was in for 10 days with his heart attack. So the climate has changed. People aren't needing hospital beds. They're not needing aftercare. Pregnancy care is a whole new game. So, you know, in that environment, we're able to do things at every phase of healthcare without a hospital or with much shorter stays and less need for a hospital. The exception, and this is ironic, is that people who don't have insurance or are underinsured get into the hospital in dire straits. They need chronic care placement, and nobody will take them because of their lack of insurance or availability to obtain Medicare and Medicaid. And we're stuck with them. You know, I say stuck, but merely financially. They're in the hospital using services, and sometimes for 20, 30, 60 days, while we arrange for sometimes who is in charge of that person's care, arrange for financial opportunities, and try and find a long-term facility for many of these placement issues that can unburden the hospital of their costs. So we're all aware of those things within the hospital, the care providers.
Mark, I want to put you on the spot, so feel free to tell me you don't want to answer. It's an opinion question.
Okay.
A lot of what you said sounds like it's not a very good thing that people are in the hospital for less time now. In your opinion, in your professional opinion, is it a good thing or a bad thing or just a thing?
Insofar as it can be done, it's an amazing thing, and it's a wonderful thing. That somebody can go home the same day from appendectomy and feel, have pain medication and not be at risk for infection. That's amazing. Insofar as sometimes payers don't allow hospitalization at the physician's discretion, and in cases where it's needed, and to provide services for people, I will say insisting, but encouraging by their payment methodologies them to go home possibly before it would be easier for them to be home. That's difficult.
Thank you so much. Before I turn the podium over to you all, I want to first extend some thanks for this forum. First of all, Mayor Shane Gallagher graciously and immediately offered this place for us. So thank you very much to Mayor Gallagher, City Council